Welcome, everyone, and thank you for joining us for today's webinar, Radiation and Uterine Cancer, What You Need to Know. I'm Kitty Silverman, the Uterine Cancer Program Director at SHARE. Before we begin, I'd like to tell you a little bit about SHARE Cancer Support. We are a national nonprofit dedicated to providing education and support for anyone affected by breast or gynecologic cancer, as well as community outreach. We recognize that cancer affects every community, so our programs are inclusive and welcoming to individuals of all races, ethnicities, ages, gender identities, sexual orientations, and backgrounds. In addition to webinars like this, we offer support groups, support lines, outreach, navigation, and other free programs. You can learn more by visiting our website at sharecancersupport.org. At SHARE, we believe no one should face cancer alone. When you come here to gain knowledge, whether you come here to gain knowledge, to feel understood, or to connect with others, we're happy to have you here. Before we dive in, a few quick reminders. All participants will be muted during the presentation. Closed captioning is available. Click the live transcript button at the bottom of your screen to enable subtitles. After the presentation, we'll have a Q&A session. You can submit questions at any time during the Q&A box located at the bottom of your screen. Please remember that presenters cannot give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and streamed to YouTube Live. The link to the recording will be available right after the webinar on SHARE's YouTube channel. Now I'm excited to welcome our speaker, Dr. Vishal Gupta. Dr. Gupta, the screen is yours.
Hi, good afternoon. I'm Dr. Gupta. I'm a radiation oncologist at Mount Sinai Health System in New York City. I've been part of the gynecologic disease management team here for over 15 years now. I work with the gynecologic oncologists, medical oncologists, pathologists, radiologists, all to ensure the best outcomes for patients. And we are involved in multiple research trials, both institutional driven and nationally and international trials. So I would like to start with my slides. I'll start sharing my screen.
Not yet.
Not yet.
You can go ahead and put them up when you're ready.
Okay. Okay. So the talk will be radiation and uterine cancer, what you need to know. Start with the background, and then we'll talk about general treatment options for endometrial cancer, and I'll specifically talk about radiation treatment and their side effects. Just general background anatomy. The uterus is here in the middle. At the bottom portion of the uterus is the cervix. On the sides of the uterus are the fallopian tubes and the ovaries, and then below the cervix is the vagina. Next to the uterus and cervix is this tissue called the perimetrium. These are ligaments that support the uterus inside the pelvis, and this becomes important for staging, which I'll get into in a second, but that's how the organs lie in relation to each other. If you're looking from the front, from the side view, you'll see the uterus is usually leans over on the bladder. This is the bladder here. You can see the urethra, the vagina, and the rectum are all in close proximity to each other. And that is important to know because the side effects of treatment often are due to the proximity of the bladder, urethra, rectum in relation to the uterus. This is a diagram of some of the lymph nodes that are surrounding the uterus, including the periaortic lymph nodes that lie above the uterus, almost at the level of the belly button. And then you'll see that there are lymph nodes surrounding the uterus on the left and right sides as well. Lymph nodes are important. They are usually, in our bodies, we have thousands of lymph nodes. They usually help us fight infections, but lymph nodes can be a bad thing in that sometimes cancers can spread through the lymph nodes. So potentially cancers can go from the uterus and into the lymph nodes, and then they may kind of march upwards in the body towards the chest. So these are important things for us to know when we're determining stage and treatment for cancers of the endometrium. So I wanted to get into the different treatment options available for endometrial cancer. So one option is to do a hysterectomy, another is radiation, and then another is chemotherapy, which you can also add in immunotherapy in that section as well. So just going back through the history of cancer treatment, these are fairly basic concepts, but I just wanted to make sure everyone's familiar with them because sometimes we do get questions about the history of cancer treatment. So there has been documentation that people were doing surgery for cancers more than 5,000 years ago. I think the Egyptians were doing breast cancer surgery well ahead of what anyone would think they would. And it wasn't until about 1895, so several thousand years later, there was only a second option for cancer, which was in the form of radiation. So Willem Röntgen discovered X-rays. This is actually a picture of the first X-ray ever taken. It's his wife's hand with a ring on it. And in 1896, so just 1 year after X-rays were discovered, there was a medical student in Chicago who opened the first radiation treatment facility. He noted that if he put radioactive substances on literally just on top of a cancer, that the cancer would shrink. And so he started using radiation treatment to treat cancer before even 1900. This is a picture of his hands after handling radiation for so many years. He actually needed amputations because the radiation that he was holding, the hands were not tolerating it well, and so he needed amputation. So we do not handle radiation like this anymore, but just interesting pictures from the past. It wasn't until about the 1940s that nitrogen mustards were used as chemotherapy for lymphoma. Nitrogen mustards were initially used in World War II as chemical warfare. This was a soldier from World War II. You can see these blisters that would show up after, so they actually used to sprinkle this or douse, I guess, battlefields with nitrogen mustards to incapacitate their soldiers. And so when these soldiers were put in the infirmary, they checked their blood and noticed that their blood levels had dropped significantly from these chemicals. So the thought, and this was at Yale, where they started to use these for medical treatment, was that if someone has normal blood levels and are exposed to these nitrogen mustards and it drops their blood levels from normal to below normal, what if we use someone like took someone who had leukemia or lymphoma where their blood cell counts are much higher than normal, and would we be able to normalize them with these nitrogen mustards? And lo and behold, it was successful. And so, chemotherapy was then born around the 1940s or 1950s. So I just wanted to emphasize that, surgery was the first treatment used in cancer, then radiation, and then chemo. A lot of times people will come to our clinic and we talk about radiation treatment and they ask me if it's experimental or if it's been used before. And I say, well, actually radiation's been around a lot longer than chemotherapy has. It's just for whatever reason, chemotherapy is just more well known to people, but radiation has been around a lot longer and it's more experience. So the goals of each of these cancer treatments, so the goal of surgery is to remove all or some of the tumor. It is typically used to try to cure patients of cancer. Palliation is a term we use for when patients may unfortunately not have curable disease and we're just trying to improve their symptoms. So sometimes we do a surgery to relieve pain or to relieve bleeding, but knowing that we may not be able to cure that cancer. Radiation therapy it kills the cancer cells. It does not eradicate the organ. So if we're using radiation treatment to treat, let's say, a prostate cancer, the prostate will still be intact after the treatment. The radiation kills the cancer within the prostate. So it's different than surgery where they actually removes the organ. Radiation can be used to kill a tumor off completely, or again, just to help with symptoms such as pain or bleeding. Chemotherapy also kills the tumor cells, but does not remove the organ from the diseased organ. Chemotherapy is often used in conjunction with surgery and or radiation in the curative setting. So this is a fact that I think not many people realize, that chemotherapy rarely cures cancer on its own. The exceptions are leukemia and lymphoma that I mentioned on that prior slide, but you would never use chemotherapy by itself to treat breast cancer or endometrial cancer. with the intention of curing it. It's used with surgery or radiation in those settings. Once someone has metastatic or incurable cancer, chemotherapy is then the primary treatment. So I'm going to describe surgery fairly briefly because I am not a surgeon. I'm a radiation oncologist, and there may be better talks available to you guys about the techniques of surgery. But the surgery often performed for endometrial cancer is a hysterectomy. It is usually the first step in managing endometrial cancer. There are 5 types of hysterectomies, and they're based on the extent of surgery. Type 1 is the one that removes the uterus and the cervix. It does not remove the perimetrium, and oftentimes the fallopian tubes and ovaries are removed with it. A type 5 hysterectomy is a much more invasive procedure. In addition to removing the uterus and cervix, it also removes the bladder and rectum. This is not typically done for endometrial cancer in the beginning. It's maybe used when cancers come back in a patient and they are only able to have such drastic surgeries. When you have the bladder and rectum removed, then you need some kind of urinary bag or colostomy bag to collect the urine and stool, but luckily this isn't needed very often. A type 3 hysterectomy is a little bit more extensive than type 1, and it removes the perimetrium and more of the vagina. This is typically done for cervix cancer and not endometrial cancer. So when we talk today about surgeries, pretty much we're talking about a type 1 hysterectomy. Potential side effects from hysterectomy include pelvic pain. Oftentimes we use NSAIDs and opioids to manage that. Sometimes patients have ileus and they're put on bowel rest to manage it. That's when the intestines don't work so well after the surgery. Patients can have urinary retention or leakage. They can have wound complications. They can have nerve damage that can result in lateral thigh numbness or leg weakness. Physical therapy is often used to help recover that function. Since the ovaries are often removed with this surgery, patients go through surgical menopause. So if the patients are not already postmenopausal, the surgery would put them in menopause, and they might develop hot flashes and other menopause symptoms. Lymphedema is swelling in the legs that can develop after surgery. This is not commonly seen these days. This was seen more frequently when surgeons did aggressive lymph node dissections. Now most surgeons are doing sentinel lymph node biopsies that are less invasive and have been shown to be equally effective. And so most institutions these days in the US are doing sentinel lymph node dissections rather than full lymph node dissections, and therefore we don't see lymphedema that often. But if they do develop lymphedema, you can use compression stockings and physical therapy to help reverse. After hysterectomy, the uterus and cervix have been removed, and the surgeons create what's called a vaginal cuff. Essentially, they stitch the vagina closed, so now it's a blind end. And so I just wanted to point that out because some of the treatments we're talking about will be referring to the vaginal cuff. So I wanted to make sure everyone was aware of what that is. And again, its proximity to the bladder and rectum. Next, we're just going to discuss staging for endometrial cancers. So in 2009, they developed a staging system that had modified the earlier versions. So I want to briefly go through the 2009 system. And so a stage 1 endometrial cancer is one that is limited to the uterus. So this entire structure here is called the uterus. The inner part of the uterus is the endometrium, and typically endometrial cancers start on this inner lining of the uterus. And so we typically use the terms that uterine and endometrial cancers. We kind of interchangeably use them, but really what we're talking about is these cancers that start in the endometrium that grow into the muscle of the uterus. If the tumor involves less than 50% of the myometrial or the muscle wall, then it was considered a stage 1A. If it goes beyond 50%, then it's a 1B. So it's not the volume, it's really just how thick is this. The pathologist measures how thick this wall is, and then they figure out how deep the tumor goes into that muscle wall. So it's not a 50% volume, it's just about how much through the distance it travels through the myometrial or the muscle wall. Stage 2 is when it involves the cervix. Stage 3 is divided up into 3A, which is the adnexa, which means fallopian tubes and ovaries, or the serosa, which is the outer lining of the uterus. So if a tumor has 100% invasion through the uterine wall and it invades the outer lining, that is considered a 3A. 3B is the perimetrium. So the perimetrium, again, is that tissue that sits next to the uterus and cervix. If it involves the perimetrium or the vagina, and tumors can sometimes spread directly into the vagina, or the tumor cells can actually break off the main tumor, go through the cervix, and implant into the vagina, and it can actually be a separate tumor. But if the vagina is involved either with direct involvement or by what's called a drop metastasis into the vagina, it's considered 3B. 3C is when the pelvic lymph nodes are involved or the periaortic lymph nodes. And then stage 4 is when the tumor invades directly into the bladder or rectum, or when it is spread into the lungs or bones or some other organ. In 2023, they completely revised the staging system. Shouldn't say completely, they kind of modified the pre-existing one. It's very, very complicated, and to be honest, I still need to occasionally look up certain tumor stages when we're applying this. This has become very cumbersome and very difficult to use, but it was felt that this is more prognostic and better helped us figure out who was at risk for cancer recurrence and who needed to be treated more aggressively. So it started to incorporate things like lymphovascular invasion, which lymphatic vessels are essentially the highways to the lymph nodes. I mentioned that sometimes cancer is spread from the uterus to the lymph nodes. In order to get to the lymph nodes, they need a highway. And so if the tumor is in that highway, that's now incorporated into the staging system, because these patients tend to do a little bit worse, meaning they have more likely to have recurrence. And they also have added into the staging system the different types of endometrial cancer. The most common is endometrioid adenocarcinoma, but there are other types like uterine papillary serous or clear cell that are more aggressive. So those are now included into the staging system. And they have also added a molecular component to this staging system. So I wanted to mention that molecular subtyping is highly recommended at this point by the staging system, and they have classified them into 4 different groups. One group is P53 genetic mutation. This is something that is done to figure out exactly how aggressive the cancer is, and these patients who do have an abnormal P53 gene have a worse prognosis. This has been shown in multiple studies, so we may tend to treat these patients more aggressively. Patients who have a POL-E mutation tend to have a good prognosis. POL-E stands for DNA polymerase epsilon gene. It is involved in DNA repair in the cancer cells. So if these cancer cells cannot repair themselves, the cancer cell will die, which is a good thing for patients. So the patients who have POL-E mutations have a good prognosis, so maybe we would treat those less aggressively. Mismatch repair deficiency. So mismatch repair, again, refers to the ability, this time of normal cells to repair themselves. So they have an intermediate prognosis. This is linked to Lynch syndrome, which used to be known as human non-polyposis colon cancer, colorectal cancer. And so patients who have this Lynch syndrome are at higher risk for developing colorectal cancers and gynecologic malignancies. So patients who have this syndrome have an intermediate prognosis. And then there are patients who have no specific molecular profile who also have intermediate prognosis. So there has been a big push to classify all endometrial cancers into one of these 4 categories. I can tell you not every institution has ability to do these subtyping, so it's become tricky with the staging system. even at Mount Sinai, which is a major medical center in New York City, we have to send this POL-E mutation analysis to a different institution since we do not do it in our hospital. It can take several weeks. Again, this is a limitation of the staging system where they recommend these molecular subtypes, but they can't require it since not every institution is able to do it. But one of the big changes in the new staging system is to do these molecular subtypes. Okay. So overall survival by stage, these are general numbers. So stage 1 cancers have about an 85% overall survival, stage 2, 70%, stage 3, 50%, and stage 4A, 15%. So I mentioned that the hysterectomy is the first part of management, and depending on what is found at surgery, we may recommend further treatment. Luckily, most women do not need further treatment after the hysterectomy, but there are certain factors we look at to decide who is at risk for their cancer recurring. So it depends on the type of endometrial cancer. I mentioned adenocarcinoma is the most common. Other varieties include papillary serous carcinoma, clear cell carcinoma, so those are more aggressive. We look at the stage of the cancer, including the depth of uterine invasion. Did the cancer involve the cervix? Did it involve lymph nodes? We look at the grade of the tumor, which implies how aggressive the cancer is. These tumors are graded on a scale of 1 to 3. 3 is the most aggressive, 1 is the least aggressive, and grade 2 is somewhere in the middle. Lymphovascular invasion, I mentioned, are those highways to the lymph nodes. We look at the uterus itself to see if the highways were involved in the uterus, because if they are involved in the uterus, that means that it may be traveling to the lymph nodes had we waited some more time. We look at the patient age. The older patients are, the more aggressive their cancers tend to be. This has been shown in numerous studies. Based on these risk factors, we group patients into low, intermediate, and high risk groups. So patients in the low risk group have a less than 5% risk of recurrence after surgery alone, and therefore no further treatment is needed for these patients. Intermediate risk patients, these patients have a 10 to 25% risk of recurrence after surgery alone. Radiation may be recommended in these patients to reduce that risk of recurrence. The most likely site of recurrence in intermediate risk patients is the vaginal cuff, which I mentioned is the resultant area that the surgeon creates after the uterus has been removed. Radiation after surgery improves the risk of recurrence to about 10%. But it has not been shown to improve survival. So we really have to look at the risk and reward to determine if a patient is a good candidate for radiation after surgery. High-risk patients, these patients have a more than 50% risk of recurrence after surgery alone. The recurrence may be in distance, meaning lungs or bones, or within the pelvis itself. Often we recommend chemotherapy, possibly with radiation. Chemo has been shown to improve survival, and so we generally recommend chemotherapy for patients who have high-risk cancers. Radiation reduces the risk of the cancer coming back in the pelvis. If radiation is given with the chemo, it can be given during or after the chemo. The typical chemotherapy regimen that's used is carboplatin and paclitaxel. It's typically given every 3 weeks for 6 cycles in high-risk patients. Possible side effects of chemotherapy include neuropathy. That's where patients have kind of the pins and needles sensation in their hands and feet. We treat these with gabapentin, Lyrica, and physical therapy. Patients can lose their hair from this regimen, and we can often manage these with hair prostheses or cooling caps. Nausea is managed with antiemetics, steroids. Patients can have fatigue. Their blood counts can drop from this chemo regimen, and then they may have decreased appetite. And there are some options to manage those. Immunotherapy is also being used in stage 3, stage 4, and recurrent metastatic disease. The typical immunotherapy agents are pembrolizumab and dostarlimab. Chemotherapy and immunotherapy has been shown to be more effective than chemo alone in these high-risk patients. And the immunotherapy tends to be most effective in patients with a deficient mismatch repair. So again, I mentioned the molecular subtype that's recommended by the staging system. And so part of it is to figure out who is going to benefit most from immunotherapy. Immunotherapy generally has mild to moderate side effects, but occasionally patients do have some severe side effects in which they cannot tolerate it at all. I'm going to focus the next portion on radiation treatment itself. So there are different types of radiation treatment that we can use in endometrial cancer. The most common way of treating patients in our department is teletherapy. Tele means distant, like telephone. So the radiation comes from outside the patient. It's also known as external beam radiotherapy. The machine we use is called a linear accelerator. We call it a LINAC for short. This is a picture of the first linear accelerator ever created. It was in Stanford in the 1950s. This is a little boy who has tumors in his eyes. This right eye is actually a glass eye because it had been removed. He also had a tumor in his left eye. And so in order to maintain his vision, they used radiation treatment with the linear accelerator to cure the cancer in his left eye so he can maintain his vision and cure the cancer. This is a modern day linear accelerator. The radiation comes out of this machine and you can see the patient is laying flat and the radiation is being aimed at her pelvis. Sometimes I get questions about CyberKnife. It's advertised a lot on TV and so people ask about it. It's not really used in gynecologic cancer, so I'm not going to talk about it much further, but it's pretty much a radiation machine that's on this arm that can move in various directions. It's used for other cancers, but not really gynecologic. Gamma knife is another one that's advertised heavily, and so I just wanted to make sure people understood that that's pretty much just used for brain tumors and not in gynecologic cancers, and that's what that machine is. And there's another type of radiation machine called a proton therapy. Again, not typically used in gynecologic therapy, except for in patients who have had prior radiation to the pelvis. We may consider proton therapy, but this is a very special situations. But generally, gynecologic cancers are not treated with proton therapy. So another type of radiation treatment is brachytherapy. Brachy means short, meaning the radiation is going a short distance. We can deliver brachytherapy through a cavity, in which case is called intracavitary. So a fairly typical example is when patients have breast cancer and the surgeon cuts out the tumor, they create a cavity, and then they put a radiation balloon into that cavity and deliver radiation from within the breast, within that cavity. This is another type of internal brachytherapy technique called tandem and ovoid brachytherapy. This is usually done for cervix cancer. The cervix sits right here. This would not work in endometrial cancer because typically everyone has surgery first, so the uterus and cervix has been removed, so we can't stick this device inside. This is a cylinder that is often used in endometrial cancer. So this is a device that goes into the vagina up against the vaginal cuff. So that was a type of brachytherapy we use for endometrial cancer. Interstitial brachytherapy is really, I'm just going to mention this to be complete. The most typical kind is prostate brachytherapy, where men would have radioactive seeds implanted into the prostate itself. It requires needles that pierce through the tissue. So the needles are creating the cavity, whereas in intracavitary, the cavity is already there. You can use it in lip cancer. So this is needles going through a lip there with a cancer right there. And then also breast cancer can be treated this way, where we put needles through the breast. So I had mentioned external beam radiotherapy or teletherapy as one of the radiation treatment options. The target is in endometrial cancer is the vaginal cuff, the perimetrium, and the pelvic lymph nodes. Occasionally, we will also target the periaortic lymph nodes, but generally they're not included. This is typically a daily treatment, Monday through Friday for 5 weeks, and we typically only offer external beam radiotherapy for high-risk patients. There are exceptions, but generally this is a high-risk treatment. I should say high-risk treatment. It's a treatment for high-risk patients. Brachytherapy is the device we use is cylinder, as I mentioned in the previous slide. The target of this is the vaginal cuff only. As I mentioned previously, the most common site of recurrence in intermediate risk patients is that vaginal cuff. So brachytherapy is often all they need. The external beam treats a much wider area. And so it really just depends on the situation and what is at risk. We often do 1 to 2 treatments per week over 3 weeks. There are different ways to do this. It's really, there's some subtle differences, but 1 to 2 per week over 3 weeks. And again, we use this in intermediate risk patients. Here's a diagram of what a cylinder, or a picture of what a cylinder looks like. This cylinder would go flush against the vaginal cuff. This is a hollow tube, and the radiation will be inserted through this tube. It takes about 5 to 10 minutes for it to travel up and out of the cylinder. The cylinder generally doesn't go in all the way. It pretty much goes into, about this much of it will go into the vagina, and the remainder stays external to the patient. So again, I wanted to bring this slide back because I wanted to talk about the anatomy. So I mentioned the external beam targets the perimetrium, the upper vagina, and the lymph nodes that sit adjacent to where the uterus had been prior to surgery. So that's why we use the external beam to target those areas. And then for brachytherapy, we really only treat the upper vagina and the vaginal cuff. Okay. The radiation dose is measured in a unit called gray. So instead of milligrams, like a lot of medications are measured in milligrams, radiation is measured in a unit called gray. When we treat with brachytherapy, we typically treat between 20 and 30 gray total. Patients get 4 to 7 gray per treatment. We do 1 to 2 treatments per week, and it's 3 to 6 treatments over 3 weeks. External beam, we typically go to 45 to 50 gray. Patients get about 2 gray per day, and we give 25 treatments over 5 weeks. So this is a more aggressive treatment that's done over a longer period of time, daily over 5 weeks, whereas brachytherapy is a pretty short course. We can treat in just about three treatment sessions or 6, depending on where the situation. This is a slide looking at the dose of the radiation. So these 2 images are for external beam radiation. These 2 images on the right are for brachytherapy. So when we treat with external beam, I mentioned that we try to go to a dose of 50 gray. So everything within this red square or rectangle is getting that full dose of 50 gray, including the vaginal cuff, the pelvic lymph nodes, and the perimetrium, which sits right about here. The other areas that get 50 gray are the intestines and the rectum. Even though we're not targeting them, they can get full dose, which is why patients can get some diarrhea, and the bladder is lower down, so patients can get bladder irritation from this treatment. You'll also see 25 gray, which is kind of half of the dose of prescribing, spreads around the rest of the pelvis. This is typically considered of little significance. It doesn't really cause side effects, but it is just something to note that the radiation dose does scatter around a little bit. When we treat with brachytherapy, this is the white thing in the middle is the cylinder inside the vagina. The dose really just focuses on the vagina, whereas this dose, you see how widespread it is throughout the pelvis. And then half of the dose is really, again, only going to a small area of the bladder, and this is the rectum back here. And so it's really little dose goes to those structures, and so this has very little side effects. Generally, people who have external beam have more side effects than the patients that get brachytherapy, because the radiation dose is going to a very small area in brachytherapy compared to the external beam. We can use fancier techniques these days to minimize dose to the bladder and rectum and the bowel, but that technique is called IMRT, and it is a little bit more targeted way of delivering the external beam radiation, but it is not as targeted as brachytherapy. Okay, so I wanted to describe the simulation. The simulation is a little bit of, it's kind of a practice session for the radiation. It's where we get a CAT scan of all of our patients we're going to treat. From this CAT scan, here's a picture of a CAT scanner. Here's a patient lying in a CAT scanner. We usually have some kind of immobilization device that helps the patients lay still. And this is done to help reproduce patients in the same position every day for treatment. So we create kind of a mold and figure out what position is comfortable for them at this simulation, and then we use that same mold for each of their treatments to make sure they're in the same position. And then we have the patients do a CAT scan while they're in that mold. And then we are able to, and here's one for the gynecologic cancers where their legs are maybe in a cradle of some sort, and that helps us position them every day for the external radiation. And then on that CAT scan, we actually draw the tumor and the normal structures such as the bladder or the rectum, because we're trying to tell the computer programs where we want to focus the radiation and where we want to avoid radiation. So we have to draw the tumor and the normal organs on this CAT scan. And so here we have an example of that. Here is potentially the vagina or the cervix that we're targeting. And here's the bladder and the rectum. We literally draw these in on the scan. And here are the bones, the leg bones that we contour in the femoral heads that really help us try to maximize the dose right into this tumor while minimizing the other areas nearby. So the entire treatment is based on this CAT scan. Okay. So just so you understand how the patients flow through our clinic, patients are diagnosed typically by a gynecologist, and then they're referred for hysterectomy. And then if the patients need to have a consultation for radiation, they come to us for a consultation. And then if we do a simulation, it's usually done within a week or so of that consultation. And then it takes 1 to 10 days to plan the radiation treatment. There's a lot of calculations and second checks we do. So it takes us about a week or so to start the radiation treatment. And then whether they have brachytherapy or external beam, that takes anywhere from 3 to 5 weeks. And then I typically follow up with my patients every 5 years and follow patients with the surgeons. We kind of alternate follow-up for a total of 5 years. And then at that point, we generally have the patients follow up with a general gynecologist after that for annual visits. Possible side effects of external beam radiation treatment. So acutely, and acute means during or shortly after the external beam finishes, patients can get diarrhea or rectal bleeding, and there are some medications that can help manage those. Patients can have urinary frequency or urgency. I mentioned that the rectum and the bladder sit very close to the vagina, and that's why those organs get irritated from the external radiation. Patients can develop pain or bleeding with urination. They can have some skin peeling. We generally recommend topical creams even before the peeling happens. Patients can have nausea or vomiting, though it's not common for patients to have nausea or vomiting just from external beam. If they're getting chemotherapy with that external beam, sometimes they can get nauseous then. Patients get fatigued from the external beam, and these side effects typically resolve 2 to 4 weeks after treatment. I usually see my patients 4 weeks after treatment, and by then most of these side effects have resolved. Chronic side effects, these are side effects that develop 3 months or more from external beam. Patients can have diarrhea or rectal bleeding. If they have rectal bleeding, they may need to see a gastroenterologist where they do a laser treatment to kind of stop the bleeding. Patients can have frequent urination or urgency, urine leakage or stool leakage, very rare but possible. Bowel obstruction or perforation, extremely rare for that to happen. Perforation means that there's a hole in the intestines from the radiation treatment. Leg edema, we mentioned that's not really seen these days since surgeries are not as aggressive as they used to be. Bone fractures, so sometimes patients can get fractures in their pelvic bones, especially if they already have osteoporosis or osteopenia, which means kind of on their way to osteoporosis, or if they have smoking or they have other kind of blood vessel disease, or that also puts them at higher risk for these bone fractures. It's rare to have significant chronic side effects from external beam, but certainly possible. And then again, there's medications or minor procedures may be needed to manage these. Side effects from the cylinder brachytherapy, the ones that may develop during or shortly after treatment include diarrhea, pain with urination, and fatigue. They rarely require medications to treat. Again, brachytherapy really targets the vaginal cuff. There's very little dose going to the bladder or rectum. So patients often don't have any side effects, but if they do, these are generally the ones that we may see. The side effects usually resolve within 24 hours of each procedure. chronic side effects that may develop more than 3 months. Sorry, this should say brachytherapy. That may develop after more than 3 months after brachytherapy include dryness in the vagina. We may recommend lubrication or topical estrogen to manage this. Vaginal fibrosis or shortening. We give all of our patients who get cylinder treatments a dilator to prevent the vaginal fibrosis and shortening that occur after radiation. Rarely, patients can have urethral stricture, urine leakage, or stool leakage. Extremely rare to have a fistula. A fistula is an opening between the bladder and vagina, or the rectum and vagina. It's really quite rare to see that from cylinder treatments. The vaginal dryness, fibrosis, and shortening, all that scarring may affect sexual function and make pelvic exams uncomfortable when patients go see their doctors. So brachytherapy versus external beam, they have been shown to have similar cure rates in intermediate risk patients. Brachytherapy has fewer side effects. So in our intermediate risk patients, we often recommend brachytherapy. But since the patients who have high risk disease, they may be at risk for disease outside of the vaginal cuff, we may recommend a more aggressive radiation treatment. Therefore, external beam may be recommended in those high risk patients. There was a European study that compared external beam and brachytherapy in intermediate risk patients. And again, it showed similar cure rates, less long-term bowel issues with brachytherapy. There are slightly less long-term bladder issues with brachytherapy, but there's no difference in sexual function or overall quality of life. I put an asterisk here about this no difference in sexual function because I find it a little bit surprising. With external beam radiation, I almost never see vaginal scarring. And I don't feel that external beam affects sexual function much, whereas brachytherapy, it's much more common for patients to have sexual dysfunction because of the scarring in the vagina. So I found this a little bit surprising, but that was what the study reported. But to briefly mention recurrence, what if the cancer comes back? So it really depends on what treatments patients had in the beginning and where the cancer has come back. If the cancer has recurred in the vaginal cuff only and the patients have not had prior radiation, then we can often recommend external radiation and brachytherapy to try to cure the cancer. If the patient already had prior radiation, it's really difficult to give radiation a second time. This is really a case-by-case situation. I mentioned proton therapy can sometimes be used, but in general, we don't give radiation to the same area twice. We may recommend surgery, whether or not they've had prior radiation. These are very difficult situations and definitely requires a discussion amongst the radiation doctors, the surgeons, and the medical oncologists. If the cancer has come back in the lymph nodes only, we often recommend surgery and then external radiation if the patient has not had prior radiation. If the cancer has come back outside of the pelvis, such as the lungs, bones, or liver, something like that, typically these patients get chemotherapy with or without immunotherapy. We sometimes use targeted radiation, which is called SBRT, stereotactic body radiation therapy. It can be given if maybe there's only 1 or 2 tumors in the lungs. Sometimes we use SBRT. Again, these are very specific situations and there's no kind of blanket statement that we can make. And then palliative radiation can be given for pain or bleeding depending on where the cancer has come back. Current clinical trials, I wanted to mention this because it emphasizes the importance of trying to individualize treatment within this disease. There are a set of trials called the Rainbow trials. These are 4 trials that are helping to guide management based on molecular classification. So I had mentioned earlier that they have been classifying patients into 3 different molecular categories. So patients who have P53 mutations, the current trial is looking at chemo and radiation versus chemo, radiation, and a drug called olaparib, which is a PARP inhibitor. So really testing the efficacy and again increasing the aggressiveness in this P53 mutation population since they have more aggressive disease. So adding another drug into that mix. patients who have mismatch repair deficiencies, testing radiation with or without durvalumab, which is immunotherapy. So we have shown that immunotherapy is more effective in patients with this mutation. So we're trying to figure out if we should be incorporating immunotherapy in more patients with this metabolic molecular profile. POL-E mutations, I mentioned these patients have a better prognosis, and so they're looking at eliminating the risk of, eliminating radiation for intermediate risk patients. So that's interesting. They're kind of reducing the amount of therapy and aggressive therapy since these patients do so well. And patients have no specific molecular profile. If they are estrogen receptor positive, we're looking at adding hormone therapy versus chemotherapy in these patients. So I just wanted to mention some trials to show you what's being done at the molecular level to try to more individualize care based on someone's specific tumor type, rather than just saying, all right, someone with stage 1 endometrial cancer is going to get this trial. This is really trying to individualize cancer care for endometrial cancer. So in conclusion, I mentioned that surgery is the first step in the treatment of endometrial cancer. Whether or not patients need post-operative treatment depends on multiple risk factors. Patients who are categorized as low risk don't require any further treatment. Intermediate risk patients may be offered radiation. High-risk patients are typically offered chemotherapy, likely with immunotherapy these days, and possibly with radiation treatment. Radiation treatment options include brachytherapy or external beam, and in certain situations, both. Intermediate risk patients, we often recommend brachytherapy. High risk patients can have external beam and or brachytherapy. Just going back, I didn't really want to go through categorizing patients to low, intermediate, and high risk. That was it's a very complicated thing, and certain physicians around the country and throughout the world actually use different classification schemes. And so I didn't want to get into this too much because it's very, very nuanced. But it's discussion between patients and their doctors to figure out which category they fit in. And then going back to the radiation treatment, it's generally well tolerated, but there may be long-term side effects. Radiation has been shown to prevent recurrence, but has not been shown to improve survival in endometrial cancer. So whether or not someone needs radiation treatment requires a balanced discussion with your doctors about the pros and cons. Thank you.
Thank you.
Happy to take questions. I've left my email address if people want to get in touch with me. But Kitty, I think we have some, or perhaps we have some questions.
Yes, we do. Thank you so much, Dr. Gupta. Very interesting and informative. Really appreciate it. Yeah, if you have any, we'll open up the Q&A, and you can continue submitting any questions in the Q&A section at the bottom of your screen if you have any. And we'll answer as many as we can, including several that were submitted in advance. So I will start with one of those, Dr. Gupta. You talked about if cancer returns and whether whether you can do radiation again. Is surgery possible on an irradiated area?
It's a challenging surgery. Our surgical colleagues really hate operating on an area that's already had radiation. The radiation causes a lot of scarring, so it becomes a very difficult and somewhat risky surgery. It's not done at every institution, and so again, a very kind of case-by-case situation. It also depends if the person had prior brachytherapy only, or did they have external beam radiotherapy, and where is the cancer at this time, and so there are a lot of things that come into the mix. And how long ago was the radiation? Was it 1 year ago, or was it 20 years ago? These are all things that come into play and may influence our decisions.
Sure, thank you. I know you talked a lot about endometrial cancers specifically. Can radiation be used to treat uterine sarcoma or other of the more rare uterine cancers?
So yes, sarcomas can occur anywhere in the body. I actually manage those as well. And we do often use radiation for sarcomas. For uterine sarcomas specifically, there are certain stages we may recommend it in, but not everyone who has a uterine sarcoma gets radiation. So we don't use it as regularly as we do in sarcomas as we do for like adenocarcinomas or the more typical endometrial cancers.
Okay, thank you. Have there been many changes? How do the new protocols differ from protocols of the, past 5 to 10 years?
So, I went through those rainbow trials, that set of 4 trials, really looking at molecular classifications.
Mhm.
That is something very unique in endometrial cancer. There's not a lot of cancers out there in general. I treat other cancers. It's rare to start incorporating these genetic mutations into the staging system, and then also to start guiding treatment. It's a very unusual thing. It's very cutting edge, and so I'm happy to be part of that kind of growing body of evidence. We have those trials open here at Mount Sinai, so we're always looking to push the envelope and try to figure out what else is out there. But I would say those are the most cutting edge things, that basing treatment off of the molecular profile.
Okay, yeah, that sounds great. There were a few questions we received about side effects as well. Somebody was interested in learning how do you heal the vaginal cup from tissue that was potentially damaged during brachytherapy, and is it possible in certain cases that this area might not fully heal?
Yep. So one of the more frustrating complications of brachytherapy to the vaginal cuff is that sometimes the radiation can cause scarring inside the vagina, which shortens the length of the vagina, and in extreme situations completely closes off the vagina, so it becomes fused shut. Completely fused vaginas are pretty rare, but it can certainly, the radiation can shorten the length of the vagina. And that can make it uncomfortable when patients come in for exams. It can cause some bleeding, and then certainly affect sexual function as well. So the best way to manage this is to prevent it. And so we give all of our patients vaginal dilators at the end of treatment, and we instruct them on how to use it to prevent that scarring. The scarring doesn't happen the day after radiation finishes. It's a slow process that takes months to develop, and the worst of it is 6 to 9 months after treatment.
Oh.
And so we counsel patients to start using the dilator well before the scarring settles in. Once the scarring is there, it's very difficult to reverse it. And so we try to, counsel our patients, and every time they come in for follow-up visits with both myself and our surgeons, we remind the patients, you need to keep using the dilator. If they don't want to use the dilator, if they're sexually active, that can replace the dilator. We tell patients that something needs to go inside the vagina 3 times a week for at least a year. And so, either being sexually active with intercourse or using the dilator can prevent that scarring. If, patients forget, or just for whatever reason don't want to use the dilator, and then they develop scarring, it's tricky to manage. It still can be somewhat reversed, probably not completely, but we do have pelvic floor physical therapy here at Mount Sinai. Not every institution has this type of service, but they are specialists who work with patients, do thorough exams. They do some gentle massage techniques. They give them devices, much more sophisticated than just the dilator. I would say the dilator works with most of our patients, but not always. And so sometimes we have to refer our patients for pelvic floor physical therapy to help kind of reverse some of those side effects.
Oh, thank you for mentioning that. Actually, we just did with a pelvic floor physical therapist a whole webinar on that.
Fantastic, great. Maybe I should watch that, because I learned it'd be great to learn some techniques, because I often just send patients there to learn some exercises and get more thorough teaching, but I haven't been through any kind of instruction myself on that, so that'd be informative for me as well.
It's very interesting. And it's on our YouTube channel for anybody
Great.
listening today. And actually, I think you just answered this question that was submitted live. They were asking, how often and for how long do you use the dilator after external beam radiation?
So this is tricky. I don't want to contradict any other physicians out there, because there is no consensus. The one thing that everyone agrees on is you can't overdose on it. So the more frequent, the better. Some people try to recommend daily. We know that that's probably not realistic to expect of our patients. So I generally counsel my patients to use it 3 to 4 times per week, 5 to 10 minutes per session for at least 1 to 1.5 years. And then at that point, I make a decision with the patient about whether they want to continue it or not. Some patients want to continue because they feel better about it and they feel like they're doing something and helping their overall care. And some patients can't wait until the day I tell them they don't have to use the dilator ever again. They want to throw it in the garbage that day. So it varies, but that's in general what I tell patients. But I certainly don't want to contradict other physicians out there at other institutions because, like I said, I can't tell you that my recommendation is better than someone else's because there are different ways to manage it.
Thank you so much. Somebody mentioned that they had heard that in some cases, both brachytherapy and external beam radiation therapy are used. What type of cases would
Yep.
these be if that is the case, and which treatment would be done first?
So I had mentioned the staging system, and stage 2 cancers is when the cancer involves not only the uterus, but also the cervix here. So when a cancer is moving inferiorly, and not all cancers start this high up, right? You can imagine an endometrial cancer starting down here, and then it may grow into the cervix down here. Once it starts moving inferiorly like this, we get a little bit nervous that the vagina may be at increased risk. And so in stage 2 patients, they're kind of the classic patients that get external beam and brachytherapy because we want to give a little bit extra dose to the upper vagina. Even though the external beam is targeting the upper vagina, adding brachytherapy gives a little bit more dose just because we're a little bit more concerned in those patients. So we typically do external beam first, and then we do the brachytherapy after. And so that's kind of the classic case of when we do both of them.
Oh, okay, thank you. Somebody had an experience with palliative radiation therapy for advanced endometrial adenocarcinoma, 3C, and the tumor disappeared after the 10 sessions of palliative radiation without other treatments. I was just curious to learn a little more about how that could work.
Yeah, I mean, I don't know that specific situation. I don't know the
Sure.
radiation dose. It sounds like 10 treatments, which is a pretty typical palliative course. And sometimes we do see things that are really, they shrink nicely from radiation. But we typically don't consider radiation itself as the best curative treatment for endometrial cancer. There are some patients I have treated who were not surgical candidates for whatever reason. Maybe they had, a history of COPD where needed supplemental oxygen and it wasn't safe for them to get anesthesia to do a hysterectomy.
Mm.
So sometimes we will use radiation by itself, and we've had some success stories, but it's generally considered not as effective as
Sure.
surgery. So, I'm happy for that person who had the tumor melt
Sure.
away. There's, a lot of different scenarios where that could happen. I'm not sure what happened in that situation, but yes, you can sometimes use radiation by itself, but it's generally not the recommended treatment for this.
Right. I was curious about that because I was surprised. And I know you mentioned, I think, that radiation it's usually given after surgery. How many weeks after
So
surgery?
external beam can start about 1 month after surgery. The brachytherapy, I find the vaginal cuff is not healed enough at that point. So I usually wait till about 2 months after surgery to start brachytherapy.
Oh, okay, thank you. And here was one last question we're going to get to that was just submitted. If radiation can prevent recurrence, why is it not improving survival?
It's a great question. So what they have found is that, let's say, for example, you have surgery and you're at risk for cancer, and so they recommend radiation, but someone decides not to have radiation for whatever reason. If the cancer does come back, there are some treatment options that can help potentially cure the treatment at that point. Those treatments are usually quite aggressive. I mentioned there are some aggressive surgeries that may require a colostomy bag where you walk around with a bag for your stool for the rest of your life, or maybe a urine bag where you have a bag for your urine for the rest of your life. So you may end up having the same survival as someone who did have the radiation in the beginning, but your quality of life may not be as good. And so these are kind of the pluses and minuses of doing the radiation, and again, why you need to have those conversations with your doctors. So there are options to treat the cancer when it comes back, but they may be more aggressive and may have a lot more side effects that may be, preventable if you just had, the brachytherapy, which has very little side effects. That's better than the cancer recurring, and then all of a sudden you need a stool bag for the rest of your life. That's, same survival, but different quality of life.
Thank you so much, Dr. Gupta. We've reached the end of our time. Just a few little things. Thank you for sharing your time, expertise, and these wonderful answers to some very good questions asked by the audience. And thank you to every person who joined us today and for bringing your voice to this space. And you're a very important part of our community, and we're really grateful that you're here. A few quick reminders before we close. The webinar was recorded and streamed to YouTube Live, so the link to the recording will be available right after the webinar on SHARE's YouTube channel. Be sure to check SHARE's website to check out upcoming educational programs, podcast episodes, and support groups. And you can also stay connected for very up-to-date resources, etc., on our social media channels. And we truly value your feedback. You will receive an anonymous survey, will appear in your browser right when this ends, the webinar ends, and you'll also receive it by email. So please provide your input, which will really help us shape future programs that meet your needs. And thank you so much to everyone for joining us. We really appreciate your being here, and thank you again, Dr. Gupta.
Great. Thanks for your time.
Take care.
All right. Take care.
Bye-bye.
Thanks for